Good morning, everybody, and welcome back. My name is Steve Morris, and I'm chairing this session. I am Professor of Health Services Researcher at the University of Cambridge, and also I'm a co-director of the Rapid Service Evaluation team, which you've heard a little bit about already this morning. And so in this session, the title is Speed or Quality, an Inevitable Trade-off, ? And as we've heard a little bit already, we're going to hear an example of an ongoing rapid evaluation of remote home monitoring for COVID-19 patients and use of pulse oximetry at home. And really in this session, we're going to have a discussion about some of the challenges faced, sort of the practical challenges faced while undertaking a rapid evaluation during a pandemic. And so we have, there'll be two speakers in this session. So the first will be Dr. Cecilia Vindrola from University College London. She's a senior research fellow and also is the co-director of the Rapid Research Evaluation Appraisal Lab, RREAL. And then, so Cecilia's going to make a presentation describing the characteristics of the evaluation, and then we're going to hear from Professor Naomi Fulop, who you've already met already this morning, who will give her reflections on the study. Before I hand over for Cecilia's pre-recorded session, I just want to remind people of a few things, please. First, if you have any questions or comments on anything you hear, kind of at any point through the presentations, then please feel free to submit any questions or comments through the chat box on the live stream page. Please feel free to do that. I also want to just flag that on the meeting portal site, there are a few things that you might want to have a look at as well. For example, there's a resources page which has some publications, etc. on it. Also, there's a discussion wall where you can kind of post any kind of general or specific comments about the meeting. And then I also wanted just to flag that so all of the sessions at the conference are being recorded, and they will be made available on the conference portal. So basically, registered delegates will be able to access these at a later date. And actually, you should receive an email when they are available. Okay, so back to the programme then, and then so without further ado, we'll start on Cecilia's video presentation, please. And this is going to talk a little bit about what the evaluation is all about and what the streams of the research are, and then about what where the project is at right now, and also what some of the main challenges are that the research team has been facing. So if we could please play the video. Thank you.
Thanks so much for the invitation to present today. My name is Cecilia Vindrola, and I am presenting on behalf of the RSET and Brace teams. And the talk today will focus on our evaluation of the implementation of the COVID oximetry at home program. The team is a big team. It brings together two teams focused on rapid service evaluations in the UK, and it is led by Professor Naomi Fulop, who's based at UCL and who's a part of RSET. Our evaluation has focused on the implementation of remote home monitoring during the COVID-19 pandemic. And the main purpose of monitoring patients at home has been to be able to allow patients to recover in the appropriate place, so to be able to recover at home if it's suitable for them to do so, but also by monitoring them closely to be able to identify any cases of deterioration. So these can be escalated early, as the evidence has shown that if these cases are escalated early, patients will not require invasive ventilation and might not need to be admitted into ICU. Next slide, please. So our evaluation has focused on two different, has been divided into two different phases. We did some early work during wave 1 of the pandemic in the UK to capture some of the lessons that were learned by a few of the pilots that had been implemented at that stage. And that was mainly a qualitative study reflecting on their experiences of implementing some of these models. And we combined that with a systematic review that sought to document the implementation of remote home monitoring models for COVID-19 patients around the world. The second phase of our evaluation is a bit more complex, and it is combining different work streams that will explore the impact of these models, that will look at costing, where we'll also look at implementation of the models, but where we will focus on documenting implementation both at a national as well as a more local, in-depth level. And this will be focusing on maybe 14 pilots carried out across the country, where we will look at variability in relation to the type of model, geographic location, and stage of implementation as well. Next slide, please. The phase 1 of our evaluation was very helpful in terms of trying to understand how remote home monitoring models work. And also this was a very rapid study that was where we carried out data collection and analysis over a few months. And the idea was to use some of these findings to inform the planning that was happening nationally for wave 2. But during this phase 1 of our evaluation, we were able to identify different types of remote home monitoring models. So we were able to see that some of these models were operating in more of a pre-hospital manner, trying to prevent patients from going into hospital if that was not necessary. And some of these were led by primary care, while others were led by secondary care. We also identified some models that were working more as a step-down models. So these were patients who were being discharged from hospital, but where clinical teams felt that they still required a bit of monitoring at home. And we also found some models that were actually, they had a combination of both of these pathways. Another aspect of variation, I guess, in terms of these models that we found was that was in relation to how patients were monitored. Some of these models were looking at using more paper-based systems, so telephone calls to the patients and then recording that, asking patients to have a paper diary to record some of their symptoms, while others relied more on digital solutions, so using apps where patients themselves could record some of these observations, and this would be the clinical team would have access to these observations on dashboards and could identify cases of deterioration. Next slide, please. And as I mentioned before, the findings from this phase 1 were helpful in the sense of allowing us to understand how these models were working in the UK, to capture some of the lessons learned during the implementation of these pilots during wave 1 of the pandemic, and to communicate some of these lessons to across the country so that they could be used in the planning for wave 2 and what would then become the national rollout of the COVID oximetry at home program. So what we were finding was that lots of attention needed to be placed on the type of information that patients and carers were receiving. If patients were informed, they would engage with remote home monitoring models in a better way. They needed to receive clear information potentially in different languages on how to use pulse oximeters at home. We also found that patients had different preferences in relation to how they would be monitored. So while some patients engage really well with the app, several models had implemented different mechanisms to give patients choice. So if they weren't comfortable with the digital solution, to be able to have phone calls and more of a paper-based system, that was also identified as helpful. One of the things that we looked at when looking at implementation was also how how staff were organized to be able to implement the model. So we looked at the staffing, and wave one of the pandemic was quite unique in the sense that many staff were released from their jobs. Staff were redeployed. Elective care to some extent was also cancelled, and that generated a pool to some extent of people who could be made available to assist with the implementation of some of these models. And that was something that the staff that we interviewed identified as quite a unique opportunity, and they didn't know if that would be available during different stages. So that was something to take into consideration in planning for wave 2 and other additional waves later on. Other key findings were in relation to making sure that integration was happening across secondary and primary care, especially when models were led out of secondary care, to make sure that close contacts were maintained with primary care, especially as patients could be were discharged from these remote monitoring models. Timely access to pulse oximeters was also identified as essential, and that was something that lots of these different pilots were focusing on at the time of wave 1. Next slide, please. Here I've just listed a few of the outputs that we generated during that wave 1 that were helpful in the sense that they informed some of the planning for wave 2, but also informed some of the work that we have done during the second phase of our evaluation. An important thing to remember from the work that we did during this early phase was that we were not able to determine the effectiveness of these models or really look at patient experience. And these are things that we took into consideration as we were designing the second phase of our evaluation. Next slide. And another thing to consider is that we place lots of attention, even though the phase 1 of our evaluation was incredibly rapid, and it only focused on 8 pilot sites that were operating at the time. We did a lot of work disseminating those findings. We've listed some of the key ones here in terms of how those findings were used to inform decision-making at a national level and to inform this rollout of COVID oximetry at home around the country. Next slide, please. So this is what we're working on at the moment. So this is the phase 2 of our evaluation, and it's been organized according to 3 work streams. I will go into each of these in a bit more detail. So next slide, please. With work stream 1, we are interested in capturing the impact of COVID oximetry at home. So as I mentioned before, during phase 1, we were not able to do so, but this is one of the key aims of this work stream. And of course, a lot of it, and I'll come back to this when I talk about the challenges, a lot of it will be dependent on access to data, but the aim will be to be able to look at the implementation of these models at a national scale, to be able to understand if there is an impact of COVID oximetry at home in relation to mortality and in relation to use of hospital services. Next slide, please. Workstream 2, will continue with some of the work that we had already started doing around costing and around staffing models, but we'll be able to look at the cost of implementing COVID oximetry at home at different study sites, the cost involved in running the sites, and in treating patients where there are identified cases of deterioration. We'll also be able to do a cost effectiveness analysis and looking at how local and national costs of implementing these models, the impact that they've generated. Next slide, please. Workstream 3 and 4 are looking at implementation. They're looking at different levels of implementation. For Workstream 3, we are focusing on implementation at a national scale. And this will mainly be done through staff and patient and carer surveys. And this is trying to capture experiences of implementation across various different models. So trying to capture variability in terms of geography, looking at models that have worked as pre-hospital as well as step down, those that have combined both pathways, looking at models that have implemented more of a paper-based system, as well as those that have different types of digital platforms. And it will be really closely linked with workstream 4, where we will do more of a deep dive or more in-depth analysis into 14 models implemented around the country as well. And data collection for this workstream will focus on carrying out interviews with staff members, as well as interviews with patients. And the idea will be to capture in greater detail their experiences of either implementing the models as well as receiving care. With the patient interviews, what we hope to do is also to try to recruit patients who might have been onboarded onto some of these models but might have withdrawn, or even patients who have declined, to try to understand their experiences as well. Next slide, please. So throughout the different stages of the evaluation, I think we've faced different challenges, and we've identified factors that have acted as enablers as well. Key challenge has been the fact that there have been several evaluations focused on COVID oximetry that have been running in parallel, and that's taken our team has had to spend a lot of time communicating and interacting with some of these teams to make sure that we were not duplicating efforts, and that each of these evaluations in ways is complementary to each other, and that we're adding value with our work. Availability and access to data from local sites is an ongoing challenge, and also there's of course issues around, of course, quality of data, and also when looking at access, looking at timely access. So when working within rapid timeframes, that has become a constant challenge, of course, to make sure that we can deliver findings at a time when they can be used to inform decision making. We have been working with different sampling strategies for the sites. During phase 1 of the evaluation, we relied a lot more on a convenience sample of sites. In phase 2, we've tried to do a lot more work to make sure that we were looking, as I mentioned before, at different types of models. However, at the end of the day, a lot of our access depends on the willingness of sites to take part in the studies. So to some extent, the evaluation is also limited by that. Different strategies that we've identified from the very beginning that have allowed us to actually be able to carry out the study quite rapidly. Good communication with PHE and NHSE, NHSX, and other relevant stakeholders, that has been key, and that's been it's been good, and it's been frequent communication. So that's been a really important part of our study. We've incorporated a wide range of rapid research tools as well that have allowed us to collect and analyze data in parallel, and that has shortened our study timeframes as well. And our team, even though, as you saw at the beginning, it's quite a large team, and larger teams sometimes are more difficult to manage, we've been able to establish different ways of working based on frequent team meetings and linking those with external stakeholders as well. And that has allowed us to cover more ground with, of course, data collection and analysis, and to deliver findings in a timely way. Next slide, please. So there's still quite a bit of work ahead for us. We are now in the process of starting with some of the data collection for phase 2 of the evaluation, planning to start with the rollout of the national surveys for staff and patients. And we are starting to liaise with sites that will be potential case studies for workstream 4, where we do a bit more in-depth work with staff, patients, and carers as well. We continue to share findings from phase 1, findings from some of the work that we're doing, updating our systematic review, and we'll, as soon as we're able to start with a phase 2 of the evaluation, we'll start to share some of the interim findings with relevant stakeholders. We have also been designing and integrating into our phase 2 plans what we have called some evaluation add-ons, or basically these are extensions of the original evaluation plan, doing some work with NHSX to explore the implementation of different digital platforms and looking at staff and patients' experiences with these platforms. And we've also integrated an analysis of remote home monitoring care homes. So thanks so much for your time today. I hope that was useful, and I hope you've enjoyed the talk. Thank you.
Okay, thank you very much, Cecilia. It seems slightly strange thanking a pre-recorded video, but nonetheless, that was a very useful summary of the project and the findings and the methods, and some of the challenges that were faced and are still being faced in this particular topic. So if I could remind people that if there are a question that you'd like to ask about this project in any way, shape or form, then please do ask it via the live chat. And so now what I'm going to do is to hand over to Professor Naomi Fulop, who you've heard from already this morning. And Naomi is the PI on this study, and it's just going to give sort of a short talk kind of outlining kind of her reflections about the project, in particular some of the challenges that have been encountered and some of the lessons that might be learnt kind of moving forward in other similar studies. So Naomi, over to you, please.
Thanks, Steve, and thanks, Cecilia, for a great pre-record. So what I'd like to reflect on are some of the processes, because hopefully they're helpful in thinking about working at this speed and in this environment. And following on from Trish's great presentation earlier this morning, and discussions in the first session, thinking about in whose interest is this evaluation is a really important place to start. And I want to say something about its origins. So NIHR came to us, the two rapid evaluation teams, Brace and RSET, last June to put this study to us. And that had come from a group of clinicians who were working away, supporting services around the country that had developed during the first wave of the pandemic to provide remote monitoring for COVID patients at home. And they were very keen to have those evaluated and draw out the lessons for what was inevitably going to be the second wave. And I just want to give a shout out for those. There are kind of clinical advisors, Matt Inarda-Kim, who's the National Clinical Director for Deterioration and now leading the COVID oximetry at home national program. And he's going to be talking at this conference on Thursday and not to be missed. Karen Kirkham, who is a GP and a national advisor to NHS England and involved in the national program, and Alison Streetley from Public Health England. And Karen and Matt had pulled together a community of practice of about 30 sites around the country that had either implemented this model or were planning to do so, and that proved very important for the development of our study. So certainly in the initial phase, to answer the question in whose interest was the evaluation, it was very much local sites around the country, a kind of a bottom-up need, if you like. And I'll say something about how that changed over time. The other important element was we, of course, as rapid evaluation teams, we're used to working rapidly, but this was the most rapidly we've ever worked. And so it meant speeding up our processes considerably. So Judith Smith talked about the scoping that the teams need to do in order to define what the research questions are and understand what research is going to be really useful to those who have asked for it. And in our experience, well, we had hoped, I remember when we put together a proposal for the rapid evaluation team, that we said that would take 3 months. And actually, usually for most of our studies, it takes at least 6 months. Because as Judith talked about, we're working very closely in close collaboration with end users, with practitioners, with policymakers, with patients to define really what we're trying to do. In this case, we did our scoping in 2 weeks. And the reason for that was because we were on a very hard deadline to produce findings in the middle of September, which we did. So the scoping was for 2 weeks. And then we conducted the study between July and September. And that, as Cecilia said, was a rapid systematic review and an empirical study of 8 sites around the country that had implemented this model. And the way we did that was, as Judith also talked about, the importance of streamlining our processes and working in parallel. So we had a large team across RSET and BRACE. And fortunately, we had worked together, the 2 teams previously, which really helped. And as others, I'm sure, have experienced in this last 10 months, it's very much easier working with people who you've worked with before in this virtual environment than building new relationships. And so we had researchers working in parallel rather than consecutively. We used things like what we call RAP sheets, a rapid analysis process, which is a rapid approach to analysing qualitative research, which Cecilia has developed and published on. And if you're interested in more information about that, it's referred to in the preprint of our empirical findings paper, which I think is on the platform, is available there. So those speeding up our usual processes was really key. A couple of other things I want to mention. One is being nimble throughout and having to adapt to a changing environment. So in the beginning, the study started off as a bottom-up need for services out there to learn from what they had done in phase 1. Other areas wanted to learn from that and build it in, and that continued. But we then had another end user, which was NHS England, that were developing a national programme, which was then launched in November for COVID oximetry at home to support a national rollout of this model of care. So our findings from phase 1 were used at regional and local level, but also at national level. And adapting to that changing environment and changing needs is really important. And just 2 other points. One is around the dissemination, and that was really facilitated by our clinical advisors who linked us in particularly to large regional meetings around the country which were hosted by academic health science networks to facilitate dissemination. And there would be hundreds of people on those calls, and we got the opportunity to share our findings. And those hundreds of people were people who were planning their services for this winter. So that window of opportunity was really important, and our clinical advisors keeping us to our timetable was really helpful and ensured that we were disseminating at the right time when it was most needed. And they also disseminated our findings for us. So we produced a slide set which they could use as well, and it meant that we actually presented across the whole country. And working in this online virtual way also meant that in 1 week we presented to Liverpool City region, we presented to Northwest London and to Southwest region, which in pre-COVID world wouldn't have been possible. I'd just like to end finally with a challenge really about how to build in a time for reflection when working at this great speed. And researchers listening and watching will know how important that is, to sit around as a team, to chew over the findings, to be really careful about the interpretation, to test them, to go away, come back again. And it is obviously much harder to build that in when working at this kind of speed. And some of that, does get lost when you're producing quite a large study in 2 months. And I'll stop there because I think lots of questions have come in.
Thank you very much, Naomi. That's really useful to hear your thoughts, and also to move the discussion on a bit. So yes, we have several questions that have come in. So thank you very much to people for posting those. There's some around the kind of findings themselves and what the data so far is showing, and then there's some around the kind of process of actually undertaking the research as well. So first question, so thank you to Charlotte Paddison from the Nuffield Trust, who asks, within the evaluation, in what ways, asks a question about the kind of interaction and sort of sharing clinical risk between the kind of hospital staff and the primary care staff. So how did doctors in the hospital and GPs in the community manage and agree responsibility for sharing clinical risk for patients at risk of deteriorating symptoms in the community? So how in practical ways did they communicate and agree this in real time? Was that something we looked at from phase 1 of the study, Naomi?
So as Cecilia talked about, there are different kinds of models and run by different organisations. So there's broadly a pre-hospital model. This is for a service for patients to monitor them at home and escalate them to hospital only if needed. And those pre-hospital models, patients could be referred from the communities, from GPs or from hot hubs, or from emergency departments. And those services might be run by the community, by GPs, or they might be run by hospitals, or sometimes they're run by both. So agreement, they all have standard operating procedures where they agree the criteria both for admission onboarding to the remote home monitoring service, but also importantly, obviously for escalation. But those discussions absolutely need to be had, particularly where secondary and community and primary care are working together.
Okay, thank you very much. Yeah, good point. Okay, so now we have a question from Jeremy Wyatt from the University of Southampton. Thank you, Jeremy, who asks about the kind of underlying sort of framework that was used to guide the evaluation. So Jeremy asks about a very specific framework for e-health evaluation, but I just wondered if it's possible to say a few words about what the framework was that's underpinning this research.
So thanks, Jeremy. Good question. So we're drawing on a number of frameworks for evaluation, not just for e-health, but more widely. But yes, particularly looking at issues such as usability, where either for digital models or for analog models, and that usability for both for patients and carers and for staff. But you're right; those issues of safety and feasibility are all very important.
Okay, thank you. So now we've got a great question from Eileen McDonagh from the Advancing Quality Alliance. So thank you, Eileen, who asks about sharing findings. So in this study, as you've already explained, or as Cecilia explained, you've explained, Naomi, there was some very kind of close working and interaction with various kind of stakeholders in the kind of introduction of the program. And obviously, to make this kind of research work rapidly, you really need that kind of interaction. But then how do you do you have any advice about finding the balance between sharing the evaluation findings kind of early and often, and what's the advice about doing that, particularly when the findings, for example, may not be complete? So the insights are only kind of potentially half-baked. Any comments on that?
Yeah, that's a really good question, and I'm not sure that there's kind of one answer to that. I think I would say that it depends who you're sharing with and what relationship you have with them. So I talked about our group of clinical advisors, which are really kind of part of the team and who can really help with sharing early findings prior to sharing them more widely, and being clear about what the interpretation is and what we can and what's possible to say and what's not possible to say. So in terms of sharing more widely, I think it's very important to stress the caveats, which us academic researchers are very good at having caveats, but you need to be aware that those may not be totally taken on board, and so that what you say is repeated without the caveat. So, I mean, we were in that first phase, we were put under quite a lot of pressure to be able to say something about the impact on mortality. And what we could say was very limited, and we made it really clear that we couldn't answer the clinical effectiveness question in phase 1. We hope to be able to answer that question in phase 2, and there are 2 other evaluation teams working on that as well, the Improvement Analytics Unit in the Health Foundation and a team at Imperial. So I think being clear about what you can say with the data that you have and what you can't say is really, really important. And sometimes you do have to push back when some very well-meaning colleagues are pushing you to say something, for example, about the impact on mortality when it's not possible to say that.
Yes, thank you. You can't overemphasize the caveats. Yeah, okay, thank you. So the title of this session is Speed or Quality, an Inevitable Trade-off, ? Not statement. And so Diane Ketley from NHS Horizons kind of asks that very question. So would you say there has been a trade-off between speed and quality in this work so far? And so what are your thoughts about that?
Hello, Diane. And yes, totally on the point question. So I would say that the answer to that question is yes, in the sense that in that first phase, we were not able to look at the clinical effectiveness question because we didn't have the data. And we also weren't able to look directly at patient experience because the speed we had to work at in that phase, and it goes to the discussion we were having earlier about ethics and research governance approvals. We just wouldn't have got those in time to include patient experience. And those are 2 big omissions, obviously. And so that phase 1 work is limited by that. We were able to draw out lessons about implementation and how the models worked and so on, which people have found useful. But there was definitely a trade-off. in that respect. We are now in phase 2, including those very important issues, specifically to address them. In terms of the work we actually did, of course, if you're doing 8 case studies of services around the country in 2 months, what your study and the way you study it is different from if you had a year to do that. And so inevitably, while you ensure that the quality of the work, the research you do in the time you have is the best it can be, inevitably there is some trade-off there.
Okay, thank you. So a sort of quite a practical research question now from Cindy Mann from the University of Bristol, who asks about kind of the development of some of the research tools which had to be done at pace given the nature of the evaluation. So so Cecilia in her talked a little bit about some of the methods and sort of research and kind of a data collection tool. So how were those developed in the evaluation?
So I saw the question was about surveys in particular. So in phase 1, we didn't use surveys. We interviewed the clinical leads and staff running the services, and we developed those topic guides really quickly and developed from our 2-week scoping that I talked about. In this phase 2, we are using surveys. We're surveying staff and patients, and they are going through the usual development processes, but speeded up. So we have, and also based on our findings in phase 1, which of course has been very helpful for their development. But we are, in fact, we are this week piloting those surveys. And they will be going live next month.
Okay, thank you very much. And so question from Emma Hanmore from NHS England and NHS Improvement, just referring to a comment that Cecilia made in her presentation about the use of rapid research tools as an enabler. She talked a bit. So could he, maybe this is a question for Cecilia, unfortunately she's not here, but what tools was she referring to when she thinks about the rapid research tools as an enabler? So in particular, the one I'll give a shout out to, because Cecilia was involved in developing this, is something called a RAP sheet, which is a rapid analysis process to speed up analysis of qualitative data. And I can talk through that a little bit in detail, but essentially for each case study site, there's a template which we iterate as we go along, and as interviews and data are collected, the findings are put directly onto this RAP sheet, which we review regularly. And then at the end, if you say you've got 8 case study sites, you've got 8 RAP sheets, which you can use for cross case analysis. But I said that there's more information about that and references to that method in the preprint of our empirical findings, which are on the platform. That's great. Yes, we've had some questions about that. Okay, so yeah, so people can access that information on the conference portal if they find that interesting. Okay, thank you. So now a question from Priya Ramana from NHS-EI. So is there a need to repeat these rapid evaluations during COVID-19? So, for example, as we get more data, as time goes by, would it be helpful to do kind of iterative evaluations to try and to firm up the data and improve the quality of the data?
Yeah, I think that's a really good question, and not just for during COVID-19, just generally about when one conducts an evaluation of a new intervention or an innovation. So I think it's Martin Buxton who said it's always too early to evaluate an innovation, or it's too late. So I think you're right, Priya, that if you're evaluating something early in the innovation life cycle, it can be helpful to go back 6 months, a year later, when that innovation has bedded in more, has come to some maturity, more data are available to evaluate it again. And that's where in this particular case, our phase 1 and then phase 2 is helpful, but it pertains to other kinds of innovations as well.
Okay, thank you. So we've got time for one more question, which is from John Appleby from the Nuffield Trust. So thank you, John, which is more about the kind of generalizability of the data from this evaluation. So do you think it's able to provide some general results, either in terms of kind of methodology or in terms of the findings themselves about the intervention, so the home-based monitoring more generally?
Yeah, a very good question, and we are, and our clinical advisors and end users are really keen to be able to draw out some of those lessons, obviously, and there's a number of different ways we're attempting to do that. So we're asking directly service providers about whether how these lessons for these services might be transferable to other types of conditions for remote home monitoring. But also some services are and have already expanded to include other conditions, non-COVID conditions, to remotely monitor at home. And so we're including those. So in terms of the implications for services, we are trying to address that. In terms of the research methods, I hope that they would be transferable to other studies of remote home monitoring.
Okay, thank you very much, Naomi. That's great, and thanks for fielding all of the questions, and thank you very much to our participants for the really good and wide-ranging set of comments and questions that were raised. So in this session, I think where the focus has been on the potential trade-off between speed and quality in doing a major evaluation of this type of scale. I think what we've heard is that there are inevitably some trade-offs, but it's still possible to get useful information. It seems so. One of the things I think that's been really useful about this particular study is the fact that it's been done in 2 stages, and having the stage 1, the pilot phase, I think was really, really useful in terms of gaining some initial information, but also because it helped to inform the methodology in the subsequent more comprehensive evaluation.